Well, Gustavo, thank you very much for the kind introduction, and I want to express my sincere gratitude for the invitation to be here at Cleveland Clinic. It's really a great honor to participate in this really impressive streak of conferences on pulmonary hypertension, so thank you. I think first, these are the learning objectives of the discussion here: to recognize recent changes to the pulmonary hypertension definition, understand contemporary concepts for the timing of right heart catheterization in at-risk patients, and learn evolving paradigms for the treatment of patients with mild PAH. So I think in order to understand how we got where we are today, it's important to go back in time to the beginning. This is the initial document outlining the first systematic definition of pulmonary hypertension, suggesting, really based on anecdotal evidence from 6 men in a room, where one had the loudest voice and ultimately announced that pulmonary hypertension really was a disease when pulmonary artery pressure exceeded 25 millimeters of mercury. I don't think this was particularly unique for the time, but what was sort of interesting is how this remained the definition of pulmonary hypertension for almost about 45 years. In 2009, it was Kovacs and colleagues in Austria that performed a very important and pivotal retrospective analysis of early era catheterization data involving about 1,200 patients, all of whom, I should say, really were volunteers or healthy. So these really weren't clinical referrals. They were volunteers in many cases, in the pursuit of identifying pulmonary artery pressure levels that were likely to be consistent with normal. And the results from this important study demonstrated that on average, this meta-analysis identified a pressure level of about 14, which when extrapolated using 2 standard deviations above the mean, suggested that the upper limit of normal in this cohort was about 20 millimeters of mercury. And this was in large part consistent with a number of important contributions to the field of pulmonary hypertension in different venues, including right heart catheterization and echo, suggesting that pulmonary artery pressure levels below the current definition at the time of 25 could nonetheless be clinically important. You can see here in smaller studies involving well-phenotyped patients with systemic sclerosis, heart failure with reduced ejection fraction, and down the line. I want to acknowledge Gustavo's important work. He was actually really the very first investigator and group of investigators with the team that's here today to emphasize the importance of pulmonary artery pressure, specifically between 21 and 24 millimeters of mercury, and how that, in his retrospective analysis here at Cleveland Clinic, was associated with a signal towards increased mortality. I think this really set the stage for a call to action in 2013 among the World Symposium that identified this, quote, at the time, borderline pulmonary hypertension subgroup, for which more information was really needed. And I think that's one of the great strengths of our community at large, which is the constant drive to refine where we are relative to where we've been and where we're trying to go. And so in response to this call to action, I became interested in understanding whether it was possible to look at this question on a larger scale. And so we explored this issue within the VA database, which is a cohort of 84 cardiac catheterization laboratories around the United States and Puerto Rico, all linked together with outcomes. And through this effort in 2016, focusing on 21,700 unique right heart catheterizations, we were in the important position from a statistical standpoint to model pulmonary artery pressure as a continuous variable. And so you can see here the relationship between mPAP and all-cause mortality. And these data clearly affirmed the importance of a mean pulmonary artery pressure of about 25 millimeters of mercury or greater. But what we found at the time was that the risk for adverse events rose at a much lower level, around 19 millimeters of mercury. Perhaps more importantly than that specific number was the fact that almost a quarter of the patients in this referral population had a mean PA pressure between 19 and 24, and that this in and of itself was associated independently with a substantial increase in the adjusted mortality of approximately 22%. So this was not a small group of vulnerable patients, this was a large cohort, and furthermore, the effects that we were observing were not borderline, they were substantial, and these are hard endpoints in the context of mortality and hospitalization, which had a less impressive effect, but was certainly directionally similar. When we looked more clearly at the difference in risk associated with changing across the mean PA pressure spectrum, we identified an important observation, which was that the majority of risk in this cohort from the spline curve could be localized to patients who had a mean PA pressure between 19 and 24. So if you were to move someone on the spectrum from, say, 61 to 60 for an mPAP, the overall delta in outcome risk was nominal. On the other hand, if you were to modulate risk in patients between 24, say, and 23 millimeters of mercury for mPAP, we saw a substantial rise in the potential outcome risk. And so that raised the question of whether we really needed to first generalize these data in other cohorts, since the VA database was, of course, largely male, and then also understand better whether there was any functional significance to this elevation in mean PA pressure, or were we simply over time just observing the play of comorbidities on outcome. And so through a number of different studies, most recently we were able to focus on autopsy specimens from patients with cardiac disease that died with catheterization-confirmed mean PA pressures that were mildly elevated from a different cause, and use that information to identify and characterize the ultrastructure of pulmonary arterioles. And you can see in this study that compared to control specimens, even mean PA pressure levels within this 20 to 25 millimeter of mercury range were linked to a substantial increase in fibrosis and hypertrophic remodeling of distal pulmonary arterioles. So in some ways, this is an important pathological correlate, raising the question that there is evidence of end organ injury even when mean PA pressures, at least at the time of a static right heart catheterization, are observed in clinical practice. So we then went on to sort of validate our observational findings on an epidemiologic level. This is a meta-analysis that was performed by Colty and colleagues, published in JAHA in 2018. And again, emphasizing the important contributions of Gustavo here. I also want to acknowledge Tawfiq Assad and Evan Britton and the others at the Vanderbilt group who were instrumental in providing a robust data set to provide the statistical power needed really to create a nice internally consistent data set across the VA and others. And from this, we were able to affirm that the observations from the VA cohort were unlikely to be limited just to that study, demonstrating a similar trend in the increase in risk associated with mildly elevated PA pressures, whether it be estimated from echo in populations or deduced directly from cardiac catheterization. So we went sort of back to this concept of the call to action from the 2013 World Symposium document and acknowledged that there was a nice progression in the research to address this question. On the one hand, we have COVAX demonstrating upper limit of normal data. On the other hand, we have a variety of data sets suggesting where clinical risk emerges. And amazingly, they converge at almost exactly the same point. So what we're really seeing here is an upper limit of normal convergence point with clinical risk that is at about 20 millimeters of mercury in all comers at risk for pulmonary hypertension. And so I think that this may have set the stage for a change in 2018 at the subsequent World Symposium, at which time mean PA pressure thresholds were dropped from 25 to 20 for diagnosing PH, And in turn, a PVR threshold was introduced for components that would include precapillary contributions to pulmonary hypertension. And at the time, the PVR level of 3 was used, and that was based on observational data in part from congenital heart groups and others suggesting that that was a reasonable first step in terms of introducing a PVR cutoff. And as I think a lot of folks here may be really familiar with, this generated a lot of controversy on both sides of the equation. Should we have changed the definition? Should we not have? Was it worth it? And it's hard to agree with both sides that are totally opposite of one another, but somehow I did. That's where I fell on this argument. And the reason was because although I agreed that the drop in mean PA pressure to 20 made sense and was evidence-based, the question of how to fit this into clinical practice was immediately raised. So if you take a scenario that we've all seen time and again, mean PA pressure that's mildly elevated with a wedge pressure that's at present defined as normal, in order to have met this definition of pulmonary hypertension requiring a PVR of 3 Wood units, we would need also a cardiac output of 3 liters per minute. So that's really more consistent with cardiogenic shock than it is early diagnosis of pulmonary hypertension. So the definition that was introduced, although forward-thinking and very helpful, I think also slanted the focus towards diagnosing more severe cases, which I think was probably outside of the focus of what they had intended to do at the time. Well, it was really Xanthali and colleagues that were focusing on patients in the meantime who had a clinical risk factor for pulmonary arterial hypertension, and they addressed this question of whether or not the PVR threshold in systemic sclerosis cohorts could be reconsidered based on data that they had in their research center. And so they did what I think a lot of us were trying to do mentally at the time, even if we didn't have a database like this to work with, which was just think a little bit about how that new definition relative to PA pressure would change the number of patients we were capturing. And of course, I think as we've all come to agree, that we really weren't seeing an increase in the number of patients that would have met this definition because the combination of mPAP of 20 to 25 with PVR greater than 3 was uncommon. But what they did observe is that in doing so, a PVR threshold that they arbitrarily selected at 2 Wood units was sufficient to segregate out differences in outcome in the study cohort. And in addition, they also observed that if the PVR level was brought down to 2 Wood units, you would in turn capture a lot more patients than if you used a threshold of 3 Wood units. So we became very interested in that. We moved back to the VA data set, which had expanded to almost 33,000 patients at that point in time, so well beyond what we would need from a statistical standpoint to model PVR as a continuous variable. And we're able to generate this spline curve, which allowed us to do a number of important calculations. We ultimately settled on a PVR of 2.2 Wood units, but that could have been different. We could have selected 2 Wood units, we could have selected 2.3. For various reasons related to age of the cohort, we ultimately went with 2.2. Most importantly, elevated risk at PVR of 2.2 Wood units was not associated with an abnormally low cardiac output in most of the cohort. And so any changes that were associated with adverse outcome at PVR levels within this range were unlikely to be measuring patients at end-stage disease. That was an important focus for us. We did, however, observe that the slope of this relationship hinged strongly on whether patients were identified as having a normal wedge pressure at the time of right heart catheterization. I'll talk a little bit about that at the end of the talk. Versus those that presented with evidence of functional pulmonary hypertension in the context of elevated wedge pressure. In any scenario, we saw a substantial elevation in the hazard ratio for all-cause mortality that was impressive as you moved across the PVR spectrum, beginning at around 2.2 Wood units. So this allowed us to sort of expand our paradigm beyond the convergence of normal versus abnormal and really start to ask questions. How are we going to ultimately think about integrating this into potential clinical care? And we're not there yet, but I will say we're making progress, I think. And the first critical hinge point in this progression is to try and more definitively get to the issue of whether the comorbidities are underlying signals to adverse outcome in patients with mild PH. And then, of course, we don't know whether or not there are any signals towards treatment effects in this subgroup. And I want to speak very clearly on that point in just a few slides. So to help try to understand some of this, we turn to the Australia and New Zealand databases because they have sort of a unique approach to the diagnosis, capture, and management of patients with pulmonary hypertension or whom are at risk. And we'll focus first on comorbidities and discuss briefly work from Jeff Strange and colleagues published in JACC in 2019, which leveraged a national echocardiographic cohort on the continent of Australia, almost 160,000 data points, reaffirming a lot of what had been shown previously as to the association between echo and adverse outcome, even when the estimated pulmonary artery pressure is only expected to be mildly abnormal. But what was really important in the study is that those mildly elevated PA pressure estimates were also linked to important changes in right heart geometry in the form of increased right atrial area and right atrial volume, as well as an increase in the number of patients, the percentage of patients with frank RA dilation and right ventricular dilation. So it becomes more difficult now to separate the functional consequences of mild PH in light of the data I showed on the pulmonary vascular remodeling pattern previously in the talk, and now on a global scale, how this sets the stage for right heart remodeling that is probably pathogenic. And then moving back to the US for a moment, it was Huston and Anna Hemnes, who's here, and again, my friend and colleague Evan Britton at Vanderbilt Medical Center, who were able to shed even more important light on this concept, focusing in their cohort on mild pH, estimated here and defined as a pressure of 33 to 39 by echo, but demonstrating further that not only were we seeing geometric changes in the right heart, but there were functional changes that were well aligned with the data from Australia in the form of a reduction in TAPSE, which is a quantitative assessment of RV systolic function, and the surrogate for RV coupling or RV-PA coupling that we may turn to from a non-invasive standpoint, demonstrating that there is further evidence of RV dysfunction. So between these two cohorts, we're really setting the stage here that we're observing an important pathogenic effect, at least on a population level, that links mild PA pressure elevation with changes that are unfavorable to the RV. And I want to talk on the third part of this triangle here on the treatment effects. These are very preliminary data that have been published, but I think it's reasonable to introduce this concept because this is going to become more important. This cohort is going to be the target of further clinical studies, and I think given that, it's absolutely appropriate to retrospectively review data from the Australia-New Zealand cohort, where for many years they did not require a PVR threshold of 3.0 Wood units to treat patients who they adjudicated among their expert center as having a diagnosis otherwise of PAH. So I don't exactly know what the reasoning and rationale was to exclude the PVR threshold at that time, but they were able to collect and assemble data on 82 patients with PAH that fit a clinical profile you would expect as being consistent with PAH. A sizable proportion of that cohort had connective tissue disease. They were largely women, and they ultimately were adjudicated as having idiopathic half the time. Now, interestingly, in this cohort, which was assembled and studied totally differently from anything we did in the VA data set or anywhere else, The average PVR level was about 2.2 Wood units with the rest of the hemodynamic profile, as you can see. And they sort of just took a very fundamental strategy and assigned patients to treatment with either an endothelin receptor antagonist or a PDE5 inhibitor. And at first follow-up, we're able to make a number of preliminary but reasonably helpful conclusions at this early stage in the story, which is that they observed an improvement clinically in 6-minute walk distance and New York Heart Functional Class assessment over the first follow-up, and then at a longer follow-up of 5 years that they observed a 5-year survival rate that is consistent with what we see in other retrospective registry data sets among patients that have been treated aggressively at a center. So I think that this is, again, a preliminary comment. I don't mean to shift the focus on that we should treat patients necessarily. That's not what I'm advocating, to be clear. But I think that this is certainly a cohort that we're going to need to do due diligence around in terms of studying to understand whether we have a unique opportunity to delay progression or in certain subgroups the possibility of preventing moderate or severe disease altogether. So that's exciting for the field and should be viewed really through that prism of future investigation. So I want to sort of end the talk on a couple of additional points that are important in the context of hemodynamic assessment, which really gets to the issue of timing. And to illustrate that, I'll just briefly present a vignette that we've all seen time and time again. A 65-year-old man with hypertension and diabetes who's referred to your clinic for progressive dyspnea. Ultimately, a decision is made for right heart catheterization, and these are the data. You have an elevated mean PA pressure, a PVR of 2.5 Wood units, and a wedge pressure of 11 millimeters of mercury. I get probably one of these types of presentations or referrals at the VA, every week. And the first thing I do is not assume that this is precapillary pH. The first thing I do is I go back to the record and I ask, what happened just before the catheterization? And more often than not, I come to learn that they were an inpatient, for example, and they had been diuresed, maybe as much as 5 kilograms. And it raises the question, if you had referred them for right heart catheterization before you had done a full diuresis, would you have found the same data? Would you really have concluded that they had true precapillary pH, or maybe you would have identified a combined post-capillary pH phenotype, which of course steers you in a totally different direction in terms of diagnosis, risk factor modification, and treatment. So to that end, in the wider context of hemodynamic assessment of pH, I wanted to emphasize an evolving paradigm which really focuses on earlier right heart catheterization in general, with sort of revised and maybe to some extent provocative clinical criteria for considering right heart catheterization in yellow. But more importantly, in the cadence of this point that I'm attempting to make, there's a role for thinking about hemodynamic assessment prior to volume optimization. I think we really need to think a little bit more clearly about how to segregate out patients with left heart disease pH from those who seem to be presenting with precapillary pH as a way to mitigate inappropriate PAH prescription use as one example. So in conclusion, mildly elevated pulmonary artery pressure is common in referral populations. In patients with mPAP above about 20, a PVR of about 2.2 Wood units or greater is associated with increased mortality and heart failure events, and captures 60% more at-risk patients versus a PVR of 3.0 Wood units or greater. I want to just emphasize that point, that we can expect a new definition that considers mPAP of 20 and PVR of 20, unlike the earlier revision in 2018, which didn't impact the universe of PH patients. This change is expected to do just that on a substantial level. I'll also make the case that adverse outcome in this cohort is not driven by clinical comorbidities alone. Pitch for earlier right heart catheterization prior to full diuresis as a way to offset misclassification and inappropriate treatment. And most important, prospective studies are really the path forward to clarify opportunities for improving outcome in this cohort that we've been discussing. And with that, I'll end by sort of just reiterating for the group that may not have seen the most recent ESC, ERS, pH guidelines on the definition, which are in line with what we've been talking about today, and just sort of advance maybe what could be the next paradigm that we should be thinking about. Ways to capture these patients will require switching from defense to some strategy that involves going to go get them. And the way to do that is probably an integrated strategy that involves public health campaigns, emphasizing the importance of genetic and clinical risk factors, rethinking the role of right heart catheterization and timing thereof, and then also, no doubt, the integration of novel technologies such as AI that can be applied to screening tests, including electrocardiography, that might be helpful. And with that, I'll just thank everyone and reiterate, I appreciate being here. I'm a big Springsteen fan, and we're near the Rock and Roll Hall of Fame, so can't do better than that.